Thank you for coming. Not only did you brave the rain, but I realize some of you are probably traveling this weekend. So to pause your preparation and to come here just for this tonight is quite a statement. So thank you. We're going to learn a lot about healthcare tonight. But one thing I've heard as I've talked to people in the past few weeks about this forum is that not only are you going to learn something about your own personal health care, but I know most of you are here because you care about the common good for this country. And specifically, we all want health reform that will cover all of our citizens. And this is why the Virginia Interfaith Center for Public Policy is hosting this forum. Can you all hear me? Is that what it is? The bad boys in the back? Okay. All right, is that better? Okay. A favor. Please pick up your packet. Does everybody have a packet? If you could grab your packet, turn that top sheet over. And the middle sheet you'll see is an invitation to an orientation for prospective members for our chapter. And on the back of that sheet is an overview of the Virginia Interfaith Center for Public Policy. And I want to read to you just our vision right now. A commonwealth where people of all faiths strive to create compassionate communities that are just, peaceful, equitable, and sustainable. So I hope you'll take some time to read the rest of this and note that our website and email address is on the bottom if you have more questions. And members of our chapter who greeted you when you came in will be in the back of the auditorium at the end. If you have any questions, or if you didn't sign up to receive email notifications or an invitation to orientation, please do that. While you've got your packet, go back to the front and look at the overview for the evening. After Dr. Hazel's keynote address, we'll have 5 distinguished professionals from the healthcare field on a panel. Each of them will speak for a few minutes from their perspective, and then there'll be a question and answer period. When you came in, you should have gotten a large index card. Feel free to write your question on that, and we'll be collecting those throughout the night. We'll also take questions from the floor, and the panel and Dr. Hazel will be up here answering your questions. We will finish at 9 o'clock, I promise. And a few housekeeping matters. Ladies, there's no break, so just get up as you feel you need to. Ladies, your bathroom is right here outside the doors. Gentlemen, yours is about 300 feet down the hall on the right. Also, by the end, we'll probably feel like we've been drinking from a fire hose. There's so much information. But Dave Rawlins from Go Fetch Media is recording the entire event. So we will post that on our website and Facebook page if you want to go back and view it again. And finally, special thanks to our sponsors who did such a good job of getting the word out. The Fauquier Free Clinic, the Mental Health Association, both our newspapers really helped us, and they both have reporters here tonight. And finally, the PATH Foundation has been instrumental from the beginning in helping us create this forum and also identify our panelists. So at this point, I'll ask the Reverend Russ Savage to come up and give us a blessing.
Please join me in a spirit of prayer. Gracious and eternal God, maker of our common home, the earth, be with us as we gather to consider the issue of affordable health care in the Commonwealth of Virginia. Remind us that all the great faith traditions teach that at the final day, we will be judged not by how much wealth we have amassed, not by what we have built, not even by the art and music and literature we have created, but by how we have cared for the least of those among us. Confirm us in our faith that health care is a resource to be made available to all, regardless of ability to pay. Bless our speaker and panelists and each of those gathered here, that together we might enhance our understanding of the challenges facing affordable health care and renew our energy to address those challenges together. This is our prayer, and let all the people say, Amen.
My name is Bob Gettings, and I have the great pleasure this evening of introducing our featured speaker of the evening. As you all know, legislation is currently pending in Washington that would fundamentally alter the nation's healthcare system. Meanwhile, members of the Virginia General Assembly are closely following developments, knowing the changes in Washington policy inevitably will trickle down to the state level and have a profound impact on the ability of the state of Virginia to address the health care needs of its citizens. Yet as I talk to you tonight, when I go around and I talk to family members and I talk to friends and I talk to neighbors, I'm actually, I have to say, I never cease to be amazed how little most people know about healthcare policy in this country. They don't even know much about the basic features of our healthcare system. It's a sprawling system, for sure, that consumes about 1/7 of our gross domestic product. It employs over 16 million Americans. As citizens, we have a very important stake in creating a healthcare system that promotes healthy behaviors, that emphasizes prevention, that affords prompt and effective access to treatment when and where we need it. As our elected officials in Washington and Richmond attempt to forge legislation that strikes a proper balance between individual responsibility, private sector innovations, and government oversight, we as citizens have an obligation to become both better informed consumers of healthcare services and active participants in the policymaking process. We can't play this role effectively unless we spend some time educating ourselves about the healthcare system as it exists and as we strive to make it better. The primary goal of this forum is to help residents of Warrenton and surrounding communities to become more effective advocates, not only for their own health care, but for the health care of the broader community, most especially individuals that are poor and disenfranchised in our society. I can't think of anyone in the Commonwealth of Virginia that's better prepared to lead us on this journey tonight than our featured speaker. Dr. William Hazel was appointed Secretary of Health and Human Services by Governor Bob McDonnell in January of 2010 and asked to stay on when Terry McAuliffe assumed the governorship in 2014. As Secretary, he oversees 11 state agencies with over 16,000 employees and a combined annual expenditures equal to about 1/3 of the state's budget. During the 7.5 years he's been in office, Dr. Hazel has led the Commonwealth's Health Reform Initiative and been instrumental in establishing his present post, establishing the Virginia Center for Health Innovation. Prior to assuming his duties with the state, Dr. Hazel spent 22 years as an orthopedic surgeon based in Herndon, Virginia. Dr. Hazel was raised in Fauquier County. Hey, here's one for you. He actually attended part of 8th grade in this very school, Tayor Middle School. So welcome back, Bill. And he tells me that it was a pretty rough time at that period of time. I'm not quite at liberty to cite any specific dates, but I'll tell you it was a difficult time. Drawing upon his encyclopedic knowledge and experience in the field of healthcare, Dr. Hazel is going to share with us insights into the challenges and opportunities posed by the current unsettled state of healthcare policy in the Commonwealth and the nation as a whole. Won't you join me in welcoming one of Fauquier County's most esteemed citizens, Dr. William A. Hazel.
So good evening, and thank you for braving the storm to come out. And my brother saw the announcement in a wine shop in Marshall, and he advised the gentleman there that the post office was next door. I don't know why he wanted to say that, but the picture, I think, got him. So it is interesting. It probably has been 49 years, let me think, since I've been in this building in 8th grade. And when I was there, it was in the 60s, and there's enough gray hair or absent hair here in some cases to remember that this country has been through turbulent times before, and maybe came out of it for the better. There's still pieces that I think we drag with us from those days, but when I was here, it was right after the integration of schools. And you'll recall 1968, the riots in Washington and other places around the country. So we have seen the climax coming into some very unsettled and even violent times as the country has grown. And I can talk about what's going on in Washington, and I can tell you about the AHCA essentially not addressing the real problems with the small group market and the individual market, and instead taking over $800 million out of Medicaid, which will in turn take another $170 million a year out of Medicaid, or $170 million over a number of years out of Medicaid in Virginia, which is already a very stingy program. We're the 47th in the country on our per capita spend on Medicaid. It is a very tight program. I can tell you about that. I can tell you about the President's budget that came out Tuesday. And maybe if I had presented that budget, I'd be in the Middle East too. Another $600 and some billion on top of the $800 billion that the AHCA takes out of health care. Another, just for Virginia, we think probably between now and 2020, or by 2023, we'll lose $430-some million a year in social service spending. Asking the state to pick up a 10% share of SNAP. We have 1.1 million Virginians on food stamps, SNAP benefits, and the state would have to pick up 10% with no change in eligibility. That certainly isn't saving the taxpayers any money, it's just shifting the pockets. We can talk about that. We can talk about funding elimination for people with programs for people with disabilities and sign language interpreters, and I can go down the budget with you. But I want to take you a little bit different way today and follow my journey. I was an orthopedic surgeon for 22 years. I have now been in recovery from the practice of orthopedics now for about 7.5 years, I want you to know. So the world is a safer place because of that. So it's been a learning experience for me as I came from medicine and began to oversee these 11 agencies, which are called Health and Human Resources in Virginia. And just so for the record, so that I can make this official, you know, our agencies are structured. I have Medicaid, I have Behavioral Health and Developmental Services, I have the Health Department, I have Social Services, I have Health Professions, I have Aging and Rehabilitation, Blind and Vision Impaired, Deaf and Hard of Hearing, Virginia Board for People with Disabilities, Virginia Foundation for Healthy Youth, and there's one more. Oh well, someone told me never to try that in public because I'll always forget, and I think I have. I'll try. Does this work better? I don't like to be bent over like this when I'm speaking, but so anyway, these 11 agencies, and they are siloed. We refer to them as our cylinders of excellence in the holy city of Richmond. I want you to know, and we're going to come back to that in a little bit. But I kind of want to take you through something that I think is happening to the country and has implications for what we want to be as society going forward. And this is just my own meanderings. So Go ahead, Scott, and get up this first slide. This is 1999. These are the estimated drug overdose deaths. Now, let me start by saying that we do not have an opioid problem. We have an addiction problem, of which opioids is the current iteration. We've had addiction with us for a long time. We've had tobacco, we've had alcohol, and so forth. So just to know that. But red means greater than 20 deaths per 100,000. Now, Scott, go to 2004. That's the next one. And watch this red getting bigger. Hit it? Now we're up to 9. Now hit it again. All right, 2014. Red is bad. That's not a political statement. This isn't a political map. This is just, a heat map. But these are overdose deaths. Some would call this an epidemic of despair if you look at where these are occurring. Next slide, Scott. And in Virginia, we see deaths from opioids too. This slide is those from fatal prescription medications. And note the heavy blue areas down in Southwest Virginia. And for those who think our society's become homogenous, you just got to drive southwest, you got to go to Eastern Shore and other parts of this Commonwealth where our fellow citizens live, and they're different. Notice this. Now, the next slide is going to show you the deaths from heroin and fentanyl. Interesting, it's not the same, is it? There's a lesson here that the problems are not the same everywhere. In fact, in Southwest Virginia, the issue with opioids is diversion of illegal drugs, primarily, and overdoses on them. Perhaps has to do with heavy physical labor in mines, workers' comp injuries, some really bad practices. And now the big issue for causing breaking and entering into crimes is the use of Subutex or Suboxone or Subutex monoproduct, which is in the rest of Virginia used to treat addiction. Makes for an interesting problem, doesn't it? How do you solve that from Richmond? How do you solve that from Washington? I would say you can't. You have to solve it here as we get forward. And we'll talk a little bit more about that. Next slide, Scott. This is Rapanic Rapidan. These are some numbers I can tell you've seen right here. Increases in number of prescription overdoses for mortality. I think Fauquier had 23 and Culpeper 13 deaths last year that we know about. I think Madison and Rappahannock, we are not aware of any, but that doesn't mean they didn't happen. And again, this is only the tip of the iceberg with addiction. You can see hepatitis is associated with needle sharing. We also know that HIV and subacute bacterial endocarditis is associated with that. Very expensive medical issues that can grow into the entire population come as this gets spread in this particular area. And we also have this little problem with neonatal abstinence syndrome. Does anybody know what that is? These are the babies born to mothers who are addicted, and the babies are addicted when they are born, and going through withdrawal as a baby is a terrible, terrible thing to watch. And there's another issue with it too. Normal pregnancy and delivery, Chad's Hospital, they go home same day, next day. Very inexpensive, everybody's happy. A neonatal abstinence baby will stay in for a couple of weeks. In Winchester, the bills are now over $60,000 a baby just to get them home. Now I'm going to ask, these moms are addicted, they're not working, they're not insured. Who pays for that? And now, Reverend, this is the call and response portion of the sermon. So if I do say tonight, who pays? The answer is, we all do. Right, okay, so who pays for that? And who pays as these children go through life with the trauma and the sequelae of having had this addiction in utero? Who pays? We all do. We all do. How do you calculate that? And how do you create from the public policy a value equation? I can tell you that it might cost, what, $800 to $1,000 a month to treat that mom, medically assisted treatment per month. And we can tell you how much all that costs. What I cannot even begin to tell you is the social cost and the actual economic costs that come from not doing the basic things that need to be done. So where is Virginia in this health status? We are the 6th wealthiest state in the United States, by some measure, some say 7. But we're in pretty good shape if you look at us and assume we were all the same throughout. This statement, though, this is from Kaiser Family Foundation. The black areas, the poor health, the very light areas, much better health. Virginia's kind of middle of the pack in that, not particularly good. Next. Healthcare expenditures, not at the bottom, but not particularly good. Bob mentioned we spend about 18 or 19% of our gross domestic product on healthcare. The European countries are next most expensive in the world in Europe, and the most expensive there is only about 11 or 12% of the gross domestic product. So from there, we spend 50% more than they do. Who do we compete with? And when you have employer-based health insurance and all of these things, where are we losing jobs? We haven't lost a job in Switzerland in recent time. Anybody here know anyone who's lost a job in Switzerland? No, we lose them to India and Vietnam and other places where the cost of health care is much lower. So this is an economic issue for us as well, not addressing the cost of health care, or perhaps it's the lack of health. Next. And this talks a little bit about life expectancy. Now, this is interesting. We're a wealthy state, but we are not near the top necessarily in life expectancy. In fact, the United States is lagging many parts of the world in life expectancy. If life expectancy, the number of years you're supposed to live from the day you're born, is lower here than other places, and we're spending 50% more, what are we getting for our money? Huh? That's the question we have to ask. Are we even looking at, are we asking ourselves the right questions? Is something we need to ask. Next. This is some work done under RWJ grant by Dr. Stephen Wolf at VCU and his center down there. And you can see child health is number 7. Yeah, we can live with that. Children's dental problem, teens births, 11 and 12. Child adolescent overweight and obesity. Take us down the list, but infant mortality, we're 33rd. Who knew? I mean, it's not really what you would expect to be. Next. So we have developed something in the health department that we call Health Opportunity Index, and this is something that not every state has done, but it looks at sort of the social factors. Who here has heard the term social determinants of health before? Okay, do you believe in them? If you don't, I'm going to give you an analogy. If you went down into Southeast DC and saw a little African-American child in one of the projects down there, you would point to that child and say, that child is likely to have a hard life because he's not getting off to a good start. Would you agree that that's likely to be said? Odds are they overcome it. There are always exceptions. But you would say that as a rule, that is the case. Right? Well, why wouldn't the same thing happen in healthcare? Right? Where people don't get off to a good start. So look at this map. This is for adults. There are 13 different indices that go into this. And look into the areas. And what is interesting is you see the dark blue in South Side and Southwest, which everyone knows, right? Everyone knows that they're impoverished and the jobs have left there and so forth. But you can find pockets in Fairfax. Next slide, please. And what is that blue right up there in the middle? This is youth poverty, right? This is the things that impact children: crime, family stability, children in primary care access, mental health access, and so forth. You see that blue spot up there? I think we're there. That's here, right? That's here. We know, who has heard the term trauma before? Now, I'm an orthopedic surgeon. Trauma for me was when the linebacker blindsided the quarterback, okay? But now we talk about children in trauma. And this, pediatricians have known about this for a long time, and I expect Dr. Royce and family doctors have too. But we know that when children are exposed to certain stressors early in life, homelessness, hunger, prison fathers, substance abuse, domestic violence, the list goes on there, about 13, that would you all agree that it's likely those children might have some trouble in school and have some behavior issues and things like that? I see some heads nodding. I'm not sure which one is rattling over here, but you would expect that, right? So, but do you know that the studies that follow these children out for longer periods of time identify early health problems, early onset of diabetes, early onset of cardiac disease and so forth in the same population? So in addition to our kids not getting off to a strong start, we see health problems later in life as a result of trauma. Now, that little boy I was talking about who could do well, so many do, most do in fact, because there's something called resilience in the way we as human beings tolerate trauma and stress and bad times. It's called resilience. And there are ways to help build resilience if we take the time to do it. So we might even get back to that later. So then this map is economic distress in Virginia. This comes from the same Center for Society and Health that Dr. Wolf has. And by the way, Dr. Wolf is a family doctor. He's a good guy. You know,
He also wrote for the Post.
Excuse me?
He was inputting the process as part of his family practice experiences. He's an excellent writer.
He is. Dr. Royston, for you don't know, is a family doctor from up in Marshall. You all probably all know Dr. Royston. But you can look at these areas, and there are pockets, even in wealthy areas, where there's poverty. Next. And it can be broken down to even a census tract level. This is a map of Richmond. I don't have one for this area, but if you look where it says 63 years, that is in what used to be called the Jackson Ward in Richmond, which was a thriving African-American neighborhood. Some referred to as the Harlem of the South. The Hippodrome was there, culture, and they put 95, went right through the neighborhood and split it. And over there, where that is Gilpin Court, which is one of the highest violence rates in Richmond right now. Every day there's something going on in Gilpin. Linda, you're shaking your head, so you're agreeing. But go a little bit west of there. 63 years life expectancy to 77 years life expectancy, based on where you live. And it's not just Richmond. Next. This is Fairfax, one of the wealthiest counties in the country. And not growing as fast anymore, but because it's largely built out. But we see from down here on the lower right corner, life expectancy 76 to 78. The Gilpin Court folks would like to have that. But look right next to it, that yellow area, 90 to 92 and 89. You know, there is a difference even there. The next slide will show you two neighborhoods very close in Alexandria. The one up on top is called Beauregard, and down the lower, larger one is Seminary Hill. These are just a couple miles apart. And you could look at that and you could say, well, is it the demographics? Percentage of African Americans, foreign-borns, high school education, is it just the economics and income? This does impact life expectancy, and I think it does impact health and health costs, which is why the life expectancy is down. But the next one will show it is not just about minorities. This is a graph, what we're seeing now with suicides and accidental drug overdose. This is, go back once, you jumped ahead of me here, Scott. This is impressive data, and if you've been reading the articles recently, you will see that this population of white men are struggling right now around the country. And this slide looks at suicide rates by region, and the green is Southwest, which is larger Caucasian population as a percent. So we are seeing things that you wouldn't necessarily expect to see based on what we have always known. Would you all agree with that so far? I mean, it is just not the way we learned it when we grew up here in Fauquier County. Go ahead to the next one. So what we talk about, and where I think we have to go with this, is we have to think about a couple of things going forward related to health care. And this isn't debating the budget details in Washington. This is fundamentally saying the programs are screwed up. And that's a technical term in government. We try not to use it in surgery very much. But it is critical that we get our kids off to a strong start. The brain development is early, your success in life. Who are the teachers here? Has anyone heard that if you can read at grade level in 3rd grade, you will do better than if you can't? Y'all, that's pretty much assumed. Even legislators understand that, okay? But how do you get to reading at grade level at 3rd grade? If you can, the likelihood that you'll end up in juvenile justice, the likelihood that you'll complete high school, the likelihood that you go into higher education, your earnings will be better if you can read at grade level at 3rd grade. Can that little fellow that we looked at, is the odds, is he going to make it or not? That's the question I think that we have to look at as society. And are we putting the resources into that early childhood? I can tell you, until about a year and a half ago, when Virginia Early Childhood Foundation did a study, we spent $1.7 billion on kids 0 to 5 in the Commonwealth. No one had ever done that before. Because we know how much we spent on Medicaid, 1.1. We know how much we spent on women, infants, and children. We know how much we spent on Part C for kids with disabilities, but no one looks across at the population until recently. What are we spending on that, and what are we getting for our money? Is it worth it? And to think 1.1 billion of that is Medicaid. Without that Medicaid money, there's a lot of trouble. And that's just scratching the surface, I think. So we look at how communities support this. In fact, there's something called the Plan for Well-Being, and I ask you to go online and look at it. But what we've tried to do is take the measures of success out of the realm of healthcare. If legislators and Congress were going to pay for improved birth weights, we'd have improved birth weights. They don't buy that. If we were buying health, we would have bought it by now. But what I think they will buy is a child ready to go to kindergarten and read? Is a child reading at grade level? And so can we convert what we're doing in healthcare to meaningful functions of life as opposed to doctor measurements? Who here knows what their blood pressure is and can feel it? You did it only because you could take it, not because you feel it, right? But lots of things like your success in life you feel, and I think we have to reconnect those things together. And you'll find that most of the European countries that spend less than us on healthcare do much more in the way of supporting people in their houses, in their families, in their communities. I can tell you a challenge now. We know that people who are unhoused have higher medical costs. Very much so. I just read a study a couple weeks ago from Johns Hopkins where seniors called dual eligibles, they are on the Medicare program, eligible for Medicare, but can't afford the co-payments and deductibles, so the state takes that on, the Medicaid piece. They're called dual eligibles. A SNAP benefit reduces the average dual eligible cost $2,300 a year. So we're going to take people off of SNAP to save money in health care. Does that make sense? So we're missing some really basic things in our policy making here that we need to go through. So I want to go back to my silo problem. For those who've been out to the farm, I grew up a couple hundred yards from those silos. That's out past Airlie, if you don't know. And we think of silos being verticals. There's the Medicaid program, and here's the behavioral health program, and is the brain connected to the body as we go about treating? And the answer is generally no. The teeth, the dental, is it connected? No. And so that's one thing. Are the social services and the things that we do for citizens in the way of wraparound tied to getting the best outcome in healthcare? And the answer is no. They're not. But the other issue that we have in government are these silos. To the lower part are our trench silos. Fill them up with silage every fall. And they're horizontals. The work is all done here locally. In fact, we at the state really don't do very much. We pass a lot of money down, and the locals say, why are you making us do that? And we look up at the feds and say, yeah, why are we making them do that? And they look down and say, because we're sending you a lot of money. And I said, like they said. So the issue here is we have 3 different levels of government working not in concert. And the interesting thing about, for instance, that SNAP benefit I was telling you about in the president's budget, taking 10% out of the federal and putting it into the state budget does not make the need change. And in fact, they aren't changing the eligibility. So what happens? It's just a transfer. And what I know for sure is that the legislators in Virginia don't like to raise the taxes to pay for federal promises. That is a fundamental issue that we have. We either have to own it and pay for it, which is what they're trying to do now. They're pushing the decisions down here. And I can tell you that our General Assembly will do the same to your local supervisors and to the nonprofit community. We're going to turn right around and say, yeah, you know, we're going to have to deal with this, and we're going to squeeze you too. So I think that is the way this is flowing. So what we've tried to do in Health and Human Resources is look at what really the idea is, and I think the term that, since I made this slide, that I look at is well-being. How do we create well-being for our individuals? And it is so different for each of us. Well-being for me is different than well-being for my mom, who broke her hip on Monday and had a hip replacement yesterday over at Chad's Hospital. Unfortunately, she's doing well. Her well-being is different than mine. It's hard to get to that statistic, right? But what we want to do is to find ways to help people have the opportunity to be fulfilled and to do well in life. Now, you would say appropriately, isn't that your parents or their parents' responsibility? It would be. Well, what do we do with all these kids now who don't have parents? It was the Kane administration that did a study that showed the single leading cause of intergenerational poverty was a single parent head household. That's not a moral judgment. It's an economic fact. It is very hard for people to make it on one income. I'm going to show you something about that. So we're looking at how we reduce the intergenerational poverty, how we get kids to a strong start, recognize that our population is getting older and more diverse. The language is spoken, the cultures and so forth are changing. And then we have another issue here that we don't institutionalize like we used to. The answer for mental illness was put them away. The answer for developmental disabilities, put them away. That's not accepted now. And for good reason, I think, for the most part. But that makes it much more complicated to deliver the services. And where are those services delivered? Not in Richmond. Here. And that's the challenge we all have if we're going to make this work. So when I talk about where our programs go wrong, this is something that needs to be addressed. This is an example of a single mom in Richmond who comes in and goes on what used to be known as welfare. Now it's called TANF, Temporary Assisted Needy Families, which she says she has to get to work or do work search in 2 years. And everybody's pushing back. She has 2 kids. This, y'all, does everybody have a picture of this woman in your mind? Suppose I told you that she was white and that she's now divorced or her husband died. Does it change what you think? We automatically had an assumption about who this person is. And we had a judgment that you need to rethink. So we take her and we put her in, and she's got disposable income. She is now on 8 programs, including a Section 8 voucher, WIC, school lunches, Medicaid, right on down the line. It's a full-time job managing your benefits. And for our job, all the requirements are different. It turns out that we have 5 programs in social services, just that we could easily do this. We have 2.66 million enrollees, but if you put them together, 35% were in 2 programs or more, or 2 programs, and 10% were in 3 or more. But yet we're wasting money because we get different levels of enrollment, different criteria. They don't match. Who knew? And then as she makes money, she loses her benefits. Now, what do we want this woman to do? We want her to be self-sufficient. We want our kids to turn out well, don't we? I mean, that's really what we want. We need those kids to do well. We need them. Some of us are going to need them to help support us. But as she gets up to around $12 or $13, you see that big drop there? You know what that is? It's when she loses her child care. Now, I'm going to ask you, ladies, who is going to make that decision to earn more money and be self-sufficient? Who? A rare person. And yet we've asked her to make that decision several times getting there. And this is a person who started with no income and probably had to get some skills along the way too. And when she finally gets back up there in Richmond to where she's crossing neutral, she has to earn over $53,000 a year. In Fairfax, that's over $80,000 a year. In Bedford, it's $33,000 because of the different needs. So go from no work in all of this to self-sufficiency in 2 years and lose your benefits. Who wants to take that bet, folks? But that's what our policies do. They don't make sense. That's not a liberal comment. That's not a conservative comment. They just don't make sense. This is called the poverty trap. So we have to think about how we connect these dots and make these programs work to move people out. Has anybody seen any sign of that discussion in Washington yet? No, and that's what frustrates me. I knew when the Trump administration came in, they would not hesitate to break the furniture. The question was, were they going to get any new furniture? And that's still a question. They're still breaking it, I think. Next. So we do have to go from there to think about how all of these policies go together in ways that we're not doing. And this isn't just about health care, it's about how it all fits together so that we can be healthier, so that we can begin to chip away on the demand side of that cost curve. Okay, Scott, one more. Now, I think I've gone on plenty for now. Maybe the panel should come up and we could talk about addiction if you'd like. We've done a lot of work with addiction treatment. I think that's a huge need, or as the man now says, it's huge, right? You can tell I'm a fan. But I think we'll let the panel maybe come up, and then if you want to get into addiction treatment, we can do that later. But thank you all for your time.
First, thank you very much for your remarks. Very illuminating. We're going to be bringing a table out, and we'll be bringing a table out. And as our panelists are coming up, I would like to remind everyone that you received an index card when you arrived. If you have a question that you would like to ask Secretary Hazel, please write it down and pass it to the end of the row. We will not be entertaining questions during the panelists' presentations, but we'll collect cards again when we begin the question and answer period. Begin. As is evident every time we read the newspaper or turn on the news, the healthcare debate has been primarily focused on the big picture, what our national healthcare policy should be and how these policies will impact vulnerable members within our national population. However, as you have pointed out, it is states and localities that, with or without national support and national resources, must try to meet the healthcare challenges within the communities they are operating in. We have with us this evening a distinguished and accomplished panel who in each of their areas of specialization have been working to make effective and affordable healthcare available in Fauquier and our neighboring counties. The biographical information we have provided on each of our panelists is in the program, the back of the first page. But the program falls far short of what could be said of their accomplishments and their contributions to our community. Unfortunately, to preserve as much time as possible for our Q&A session, I must refer you to the program for these details. It is therefore my sincere honor to introduce our panelists. First, all the way to your right, Chad Melton is the Chief Executive Officer of Fauquier Health, which operates our Fauquier Hospital. Although Chad only recently joined Fauquier Health, he is bringing a very remarkable record of patient safety and accomplishments to our community. Chad will also be bringing more than 12 years' experience to our conversations this evening. Next to Chad is Linda Wilkinson. She's been the Chief Executive Officer of the Virginia Association of Free and Charitable Clinics since 2011. It should be noted that the Virginia Association of Free and Charitable Clinics is the oldest free clinic association in the United States, that it represents and supports Virginia's network of 61 free clinics, and that collectively these clinics are one of the largest providers of health care to the uninsured in Virginia. Steve Wojcik is Vice President for Public Policy at the National Business Group on Health. The National Business Group on Health gives voice to the needs of large employers in providing health care benefits to their employees. Steve will be bringing 25 years of experience in healthcare policy, development, and analysis to our discussion. Sally Morgan has been the Executive Director of the Mental Health Association of Fauquier County for the last 6 years. The Mental Health Association of Fauquier County has a long history of advocating for high quality and accessible mental health services in Fauquier and Rappahannock counties. And when joined with Sally's service with the Rappahannock-Rapidan Community Services Board, Sally's experience in getting service to those in need spans more than 40 years. Sorry about that. And then Bill Botts. He's retired as the Executive Director of Rappahannock Legal Services in 2011, where he is still referred to as a legend for his tireless advocacy for clients in need, as well as his extremely generous examples of philanthropy. More recently, Bill has devoted his energies to educate consumers about the health insurance marketplace as a health insurance navigator for Enroll Virginia and through events such as this forum. Thank you. Again, to preserve as much time as possible for our Q&A session, we have asked each of our panelists to limit their initial remarks to 8 minutes. Let us begin. Please.
Thanks, and I appreciate you allowing me to be here this evening. And so if you saw me hobble down the steps, I was a utilizer of Fauquier Health and Johns Hopkins a matter of 5 times over the past week and a half. And so I was lucky to be able to get a coat on tonight. So any of those who have seen me, I have some pretty deep scars. And so I know firsthand we provide great service here here in Warrenton. So I appreciate the opportunity because I've had the chance to be able to work for both for-profit and not-for-profit hospitals. And I know I'm going to get the question because it's probably a burning topic about for-profit in general. And so I'll just go ahead and address that and just say that not all for-profits are exactly the same. That I've had a chance to work all over the country in Texas. I've worked in Arizona, had the opportunity to work in Idaho, Connecticut, Florida, New Jersey, and can tell you that healthcare, like Dr. Hazel was saying, the issues are somewhat the same, but also different depending on where you live in different parts of the country. And some of the topics that we discussed earlier about behavioral health is an issue absolutely everywhere across the country and something that needs to be addressed. So we'll save that for another day. But as you know, healthcare today has really evolved, and I feel like a baby on the panel because I've only been in healthcare for 12 years, but I have the opportunity, as I said, to work all over the country. And acute healthcare has really evolved. And in the past, it really was about just taking care of patients on the inpatient side, and has evolved to more than just that. And if you know the mission statement at Fauquier Health and of LifePoint, it really is about making communities healthier. At the end of the day, it's about doing the right thing for each and every person in the community that we serve, regardless of their economic status, regardless of their ability to pay. At Fauquier Health, just last year alone, we spent almost $6.9 million on uncompensated care. And so we're not the free clinic. We support the free clinic, but those opportunities of those who are coming through the emergency department get care regardless of their ability to pay. And we don't want them utilizing the ED, but we are there to take care of our community in a time of need. I'll also say that over time, and we could talk about, again, the Affordable Care Act, we could talk about buzzwords in regards to value-based purchasing. We could talk about Affordable Care Act. We could talk about ACOs, on and on and on. Healthcare over time has really adapted, and we need to be able to adapt and grow with the communities that we serve, not only here but across the country. In healthcare, if you've known in the downturn, the economic downturn, there was really only two industries that continue to grow: education and healthcare. And so as we drive and bring new businesses in the community, that's the one thing that they really look at is, what's available in regards to the communities that we serve, and healthcare is usually number one. At Fauquier Health, we have almost 1,400 employees, and healthcare is very expensive, and I hear it every day, and people often ask me, why are we paying $5,000 for an MRI? And I could go on all day about why actual charges are $5,000 is not actually what we get paid. But if you don't know, in healthcare, the average hourly rate at Fauquier Health is $35 an hour. And I tell people, how many jobs do you have to create in the community to be able to have one job that pays $35 an hour? We, at Fauquier last year, almost $76 million in payroll. And so that's a significant number that we have here in the community to be able to support some of the services that we have. Also, as we talk about community benefit, is that at Fauquier Health and tax-paying entities, I think last year we paid almost $2.7 million in taxes that went directly back into the community here locally. And so, again, as healthcare has grown and evolved, and I wait for some more of the questions that we have coming up, is that we want to really have to provide a community service, and that each and every day we talk to our employees about giving back to the community, because at the end of the day, it's about people taking care of people, regardless if you're here or in Fairfax or if you're in Baltimore. That's really what it's about. And so I'm proud to be part of this community and have the opportunity to be able to talk about some of the issues that you may bring up this evening. Thank you.
This is on. If it's okay, no disrespect to you all in the audience, but I have severe arthritis from my hips down to my ankles, and I'm in a lot of pain right now, so going up and down there is uncomfortable for me. All right, wonderful. So my name is Linda Wilkinson, and it is my privilege and pleasure to be the CEO of the longest running association of free clinics in the entire country. How many of you have heard of the Fauquier Free Clinic? How many of you volunteer at the Fauquier Free Clinic? Thank you very much for your volunteerism. And for those of you who haven't heard about free clinics or are unaware of the Fauquier Free Clinic, about free clinics throughout the entire state, and maybe a little bit of national information as well, because I also serve on the National Association of Free and Charitable Clinics Board of Directors. So maybe we'll talk a little bit about Virginia as it relates to other free clinics. But I want to talk a little bit, very, very briefly about our association. As you already know, we are the longest running association in the country. We've been in existence since 1993, so next year we'll celebrate our 25th anniversary. And the mission of our association is to support and strengthen our member clinics so that vulnerable patients have access to health care. It's pretty simple. Our mission is relatively simple, but in case you haven't heard, healthcare is complicated. It's very complicated. And our patients are enormously complex. I'll talk a little bit about what those patients look like and what the average free clinic patient looks like in just a few minutes. But I want to tell you what free clinics are here in Virginia. Free clinics are volunteer-based safety net organizations that provide a combination of medical, pharmaceutical, dental, and or behavioral health care services to low-income, uninsured, primarily adult patients. Most of our patients are uninsured, and it's exactly what the term implies. They have no health insurance. Although in the past 2 to 3 years, you may or may not be surprised to learn that we have seen a spike in what we call underinsured patients. Underinsured patients, by our definition, are those folks who have purchased a marketplace plan and they can afford the $35 or $50 a month premium, but they can't afford the $5,000 or $6,000 a year deductible. So our clinics, some of them across the country, across the state, will serve underinsured patients as well. But for most of the data that I'm going to provide you in a few minutes, we're going to talk about uninsured patients strictly, okay? So who are these patients across the state? Well, as John said when he introduced us, I believe it was, that we have 61 clinics across the state. 61 clinics serve approximately 70,000 low-income, uninsured adult patients. They have no health insurance whatsoever. These patients are considered chronically ill. These are patients who have diabetes or COPD, hypertension, hypertension, heart disease, and or they may have panic, anxiety, or depression disorder, or some combination. The executive director of the Fauquier Free Clinic, Rob Marino, is in the audience. And Rob, I'll put you on the spot for a second, if you don't mind. Rob, I didn't tell him I was going to do this. Rob, would you say that a majority of your patients suffer from multiple comorbidities, meaning they have multiple diseases?
Absolutely.
You're saying it's over 50%? Yes.
North of 75, yeah.
So when I tell you that our patients are very complex, imagine having diabetes, COPD, congestive heart failure, high blood pressure, and hypertension, and just for fun, you also suffer from a behavioral health disorder. These are the common patients in our free clinics. These are patients who are taking 5, 6, 7 or more prescription medications. Last year, or the last year that we have our finalized data, which is in 2015, our free clinics provided over 645,000 prescriptions for 70,000 patients. So if you work the math backwards, that's what? Dr. Hazel, about 9 or so prescriptions per patient. That's a lot of prescriptions and a lot of money.
Linda, was it really free?
No, sir. Thank you for that question, Dr. Hazel. There's no such thing as free, is there? I learned that in Econ 101 back at the fine institution of higher education called Randolph-Macon. There is no such thing as a free lunch. Even though our clinics, and here in Fauquier, Rob, your clinic is completely free?
Yes, ma'am.
So at Fauquier Free Clinic, they do not charge patients. At some of our other clinics, our charitable clinics, thus our name, those clinics do charge a nominal fee for their services. It might be $2 for a prescription, or $5 for an office visit, or $10 for a dental appointment, but no patient is ever turned away for his or her inability to pay. Those prescriptions that Dr. Hazel asked me about, they're not free. That is one of the biggest problems facing our country as a whole, but most definitely our free clinics, is being able to access medication for our patients. Everyone in this auditorium has probably heard about, several months ago, the 400+% increase for an EpiPen. Okay. And a 400+% increase for naloxone or Narcan, the life-saving drug that reverses opioid overdoses. Those are very critical medications for any human being to have and for our patients to have, but our patients' struggle is more daily than that. If you have diabetes and you need insulin, the average cost of insulin, if you go to CVS or Walgreens, the average cost without health insurance is $400. That does not even take into account your glucometer and strips. That's just for Lantus insulin alone. Our patients who are 250%, 250 and 200% and below of the federal poverty level cannot possibly afford insulin on their own. It's becoming increasingly more difficult because of the pharmaceutical companies to access these life-saving medications. This is a daily struggle, and everyone in the auditorium probably knows someone who can't afford medication. There might be some folks in the auditorium yourselves who are having a hard time. I know in my own family, when my mother was near the end of her life about 16 months ago, my mother was on 15 medications. and I managed all of those medicines. My mother had Medicare, and she had Part D, but Medicare did not cover 100% of all of her medications. My husband and I were paying hundreds of dollars, and we were glad to do this, hundreds of dollars each month just to make sure my mother could get her medications. And as if it's not already frustrating enough for these medications to be so expensive for people with insurance like Medicare, Medicare keeps changing the formulary, so in January, my mother's inhaler was covered, but in April, they changed it, and now it's out of pocket. Imagine you don't even have Medicare. You have no insurance, and you are one of those statistics that Dr. Hazel put up on his presentation. And you're just struggling to make ends meet. You're just trying to make your car payment or your rent and put food on the table. This is the average patient at a free clinic. These are folks working 2 and 3 jobs. These are single moms or single dads, some 2-family households as well, of course. These are single folks doing the best they can. And they need our help. They need your help. We need to work together to change some of these public policies to help the most vulnerable of people in our society. I read an article right before I came over here to the middle school, before I left my hotel, that a person in the administration, in the Trump administration, had said, I believe it was today, said something along the lines of, poverty is a state of mind.
Dr. Ben Carson.
I wasn't going to remember.
I will tag him.
Okay, so it was Dr. Ben Carson, as the gentleman said. I was trying not to get too political, but okay, Dr. Ben Carson said that poverty is a state of mind. And I promise you that no one wants to live in poverty. It is not anyone's state of mind. No one chooses to live in guilty court. The public housing community that Dr. Hazel referred to, and then he talked about the museum district, which is about 5 minutes away from Gilpin Court, where it's a very affluent area of town. That is one of the most insulting comments I've ever heard in my life. And I've been in healthcare for 25 years and doing in the political arena for just as long. There is nothing about living in poverty that is in your mind. We have to address the social determinants. We have to address public policy and work together to effect change. As a political science major, I believe that's where the change occurs. If we can all work together, which is why I'm so pleased to be here and part of this distinguished panel, we have to work together to address these issues, educate the policymakers. I believe on most days that most members of the General Assembly in particular really want to learn. They really do care about people. They want to know how best to help their constituents, but they have to know that from us. They have to hear from us of what we want for our community. So I'm going to stop there so we can have as much time as possible for our Q&A a little bit later.
Thank you very much for the opportunity to speak here. I'm a resident of the town. I'm also one of the community representatives on the Fauquier Hospital Board. My day job, I'm in Washington, and so I'm going to talk about things from the perspective of the business community and how the business community looks at healthcare countrywide and increasingly on a global basis as well. The National Business Group on Health is, we represent about 425 large employers. The largest employer that is a member of our organization is probably an employer of some of you in the audience or your former employer. It's the Office of Personnel Management of the federal government. As well as, the Fortune 500 companies. We have 70 of the Fortune 100. So these are the largest employers in the country. And we represent them as purchasers of healthcare. So we cover in total 177 million people with health benefits and health coverage. And that's the largest source of coverage in the country. And after the federal government collectively, employers are the second largest payer for healthcare in the country. And so we take a position, our seat at the table in Washington on healthcare and health benefits issues is as a payer. And so we're always interested in looking for value. But I would say today that increasingly affordability, which is a big part of value, is also related to not only coverage, but access to care. So you can't really separate those. During the health reform debate, we stressed and emphasized that there were 3 parts, and I think this is common for anyone in health policy, that there are 3 parts to the healthcare puzzle that all have to be addressed in order for us to all have sufficient coverage so that we don't have to pay huge sums of money out of pocket for things that might not be covered or only partially covered by our healthcare plans. We have to be assured that we're getting quality as well, because that's a part of it, because no one wants to be subject to poor quality healthcare and then have to go back in and spend more money on healthcare. I think that's one of the only industries where you actually pay more when you don't get good quality or when there's a mistake made. I think we're addressing some of that through policies, but we still have a long way to go on that. And then the last one, which I think is doing a better job. I think Secretary Hazel mentioned that we spend, I think it's pretty close to almost double what the other countries of a comparable economic level of development in Western Europe, Northern Europe, Australia, Canada spend on healthcare. And as he mentioned, our life expectancy is lower than most of those countries. And our infant mortality is higher, and there are lots of other statistics that we can go through that show that we are not as healthy as it would seem to be for how much we're paying for healthcare in this country. And in order to sustain, one of the arguments that we had made, and by the way, we're nonpartisan, a political organization representing the interests of employers as payers of healthcare, not the healthcare industry. And we basically said that in order to sustain those, the growth in coverage, whether it's through the marketplace exchanges or through the Medicaid expansion, you actually have to do a better job of controlling costs. And there were some parts of the Affordable Care Act that started to make inroads in that, especially in Medicare. And from our perspective, it's a good thing because we had been trying to talk with Medicare in prior administrations and prior to the ACA to partner with employers, because think of all the power that the largest payer of healthcare would have joining forces with the second largest payer to say we need to drive better value and better quality, more consistent quality in healthcare. And so we're very grateful, and we're very grateful that there's other legislation that was passed at the federal level on a bipartisan basis overwhelmingly. There were only a few members of both the Senate and the House who voted against it. It's called the macro legislation that requires physicians who take Medicare to move away from fee-for-service, so they're no longer going to be paid based on the volume of services they do, but on the quality and the outcomes and the patient satisfaction with those services. And that's going to take a while, but we're increasingly moving away from that, and I think employers are welcoming that and working with their health plans, and some large employers where they have a significant presence in the local community are also working directly with the healthcare providers to take care of not only just of treating people's illnesses, but also managing the health of the population, making sure that people get the preventive services, the primary care that they need, the behavioral health services that they need, all of the screenings, vaccinations, and all of the other activities that encourage them to stay healthy and stay out of the hospital and out of the need for any kind of treatment. And so that's kind of a more holistic approach, and I think that hopefully the country will move there sooner than we think and than we hope, because I think increasingly it's not just an issue of healthcare for the states, it's also, and at the federal level as well, it's also an interest of it's coming at the cost of investments in education, infrastructure, and many other types of services that the states as well as the federal government could be spending. And increasingly internationally in the defense and national security community, it's becoming a national security issue in terms of how much we're spending on healthcare and how little we're getting for it, and how we have to address a lot of the healthcare needs of the population and get a healthier population. So it's broader than just healthcare. It's affecting the total economy, and it's increasingly affecting national security.
Good evening. The Mental Health Association is a nonprofit advocacy and action group that serves Fauquier and Rappahannock counties. Our mission is to promote and facilitate mental wellness in our communities. And behind among our concerns is making sure people have access to mental health and substance use treatment when they need it. And here's what we know. We know there is no health without mental health. Our healthcare system may put mental health, behavioral health, and medical services in two different silos, but our bodies do not. We know that when we attend to our mental health issues, our health outcomes improve, and vice versa. When we attend to people's physical health, their mental health improves also. What we also know, though, is that there is a tragic and costly gap between the time a person first experiences symptoms of a mental illness and when they actually get treatment. And many of you in this audience know the length of time that is. It is an astounding 10 years on average. And for many people, it's even longer than that. That delay is costly not only in terms of pain and disruption to the individual's life, to their families. It's costly in terms of healthcare expenses and in terms of lost productivity. So what's the reason for the delay? In many cases, it is related to fear, to the unfortunate stigma that is still attached to behavioral health services. It also is a matter of access. And access is partly finding providers. We have 2 psychiatrists in this community, and I can tell you that is not nearly enough. We lack providers in specialty areas, particularly in child mental health and in specific services like treating anxiety in children. It's also a question of cost, which relates to coverage, Medicaid coverage, and private insurance coverage. But also, even if you have coverage, most private providers do not accept Medicaid. Very few use sliding scales for service, fee scales. Some don't accept insurance. So if it takes someone 10 years to come to the point where they're ready to ask for help, our system has to be ready to give it at that point. And that means no waiting lists. It means care that people can afford. Now, Medicaid is a fundamental part of the affordability issue. It's the single largest payer for mental health services in the U.S., and increasingly it is paying for substance use treatment as well. We know that Virginia did not choose to participate in Medicaid expansion. The governor, however, did set up a GAP program that provided coverage for individuals with long-term mental illnesses who are uninsured and who had incomes at or below 80% of poverty. This has been a significant boon for a relatively narrow population, but a very vulnerable one, and certainly services that I hope will continue. Talked about the recent released federal budget and the movement to enact the American Health Care Act. Both of those put Medicaid in jeopardy. Paul Gianfrido, CEO of Mental Health America, which we're a local affiliate, said the day the House passed the American Health Care Act was a tragic day for all those dealing with or caring for someone with serious mental health concerns. In addition to proposed reductions in the number of Medicaid beneficiaries, one of the concerns is the provision that would allow states to opt out of several of the assurances that were provided under the ACA. So that means if it were passed, in many places mental health would not be covered by insurance policies or would be covered at premiums that would just be totally unaffordable for most people. That would be a huge step backwards from the parity between medical health, mental health and physical health coverage that advocates have worked for long and hard. So I want to tell you some good news. I think on the local front, we have some amazing things happening in this area. We have a strong community movement to support both mental health and substance use issues. We have something called the Mental Health Collaborative, which brings together the leadership of all of our important health, mental health, human service providers, our schools, our law enforcement, to set and drive a community agenda. We have the PATH Foundation, which has been an enormous boon to this community in identifying primary concerns and addressing those, and mental health is one of the, behavioral health is one of the things that they have set as a priority. I want to brag on our free clinic. We have an extraordinary model at the Fauquier Free Clinic, just really fully developed in the fall of this year. But we now have an integrated model of care, which should be the model for all care, in my opinion, in the community, where you go in for medical treatment, you get a very brief screening tool that flags whether you might be suffering from depression or possibly anxiety, etc. And you are immediately, right then and there, connected with mental health services at that facility. You get an immediate referral. There's close communication between the primary care physician and the mental health provider. And we've instituted the use of telepsychiatry and telemental health to supplement the care provided by the local counselors who donate their time to the free clinic. And all of that has been possible through funding from the PATH Foundation. Fauquier Health, Free Clinic, and the Mental Health Association are now exploring how we can take that model to the larger community. And we're looking at ideas like a wellness center where primary care doctors could refer individuals that they've screened for more full evaluation and linking with either telehealth or other mental health services. We also have, by the way, a project that the Mental Health Association and Fauquier Health have been working on to address the neonatal absence syndrome, and are going to be rolling out some really impressive new approach to find women who are addicted, who are pregnant, and address those needs before they give birth and afterwards. Our local community services board has some good news. They have instituted a rapid access program where you can now go 4 mornings a week for a few hours each morning. They will take folks to come in and get an evaluation for mental health services, no appointment needed. The trick with that is once you can do a lot of evaluations, but then you have to have a good counseling staff, adequate numbers of counselors to be able to hand people off after the evaluations. We have just received in this region another $280,000 in state money through a program I believe is called STEP Virginia, and that will help our local community services board provide that follow-up treatment for individuals that are coming in through rapid access. They've also received about that same amount of money coming through federal sources for medication-assisted treatment for individuals who are addicted to opioids. One other big change is Medicaid-related. It's a program called ARTS, Addiction Recovery Treatment Services, that is, again, providing additional resources for both inpatient treatment and intensive outpatient, case management, et cetera, for people suffering from addictions. And the final thing I'd mention is a very strong youth and family initiative trying to address both prevention and early intervention for young people who are experiencing mental health problems or are at risk of addiction. So I would just say that to ensure affordable health care, we need a strong and expanded Medicaid program. We need a strong public mental health system. That's the one place you can go and get services on a sliding fee scale right now. We need affordable health insurance options that include strong behavioral health coverage. We need to support integrated and collaborative care models like what's happening at the free clinic. I think we could use stronger policies to promote telehealth, to increase access particularly to more rural areas, and strong services for youth. Secretary Hazel talked about the impact of adverse childhood experiences. We need both prevention services and also treatment that identifies individuals early and gets them to care as soon as possible. So I would just conclude by saying, if we have the will, we can give our citizens the resources we all need to live healthy, fulfilling lives. We really can do it.
Good evening. I think we've all heard someone one time or another say, if you don't have your health, you don't have anything. Or if you don't have your health, not much else matters. We were reminded of this at Fredericksburg United Methodist Church, where I'm a member. Recently, we have a monthly community dinner for the homeless. And for some time, we have at each table, for each person, been handing out 3x5 cards where they can write out their prayers, print out their prayers, and then they are shared with the congregation and they go on the church website. We recently culled through those to see what indicators of their needs were there. Because this forum tonight is about health, I think you know where I'm headed. 80% of all prayers concern health, one's own health or the health of others. The topics of food, shelter, and a job only constitute 20% of the content of the prayers. So I think that's a dramatic example of if you don't have your health, nothing else matters. I became interested in health in the 60s. I'm old enough to be considered, I guess, a child of the 60s. And in the 60s, the Great Society program came along, and with it came Medicare and Medicaid. That was fiercely opposed at the time. And one of my heroes, the Reverend Dr. Martin Luther King Jr., made a rather famous address to the medical community on human rights during the debate on whether to have Medicare and Medicaid. And he said, quote, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane because it often results in physical death. I see no alternative to direct action and creative nonviolence to raise the conscience of the nation." That was in 1966. Within 1 year after Medicare was enacted, there were 19 million people enrolled in Medicare. As of 2015, there were over 55 million. By 2016, over 74 million were enrolled in Medicaid, CHIP, or FAMES. All of these programs are now being threatened. And I think it comes down to debate in our democracy about whether health care in America should be a right or a privilege. We had a meeting, a community meeting with a local representative, Rob Whitman, last Friday. He danced around a lot of questions, being the adept politician he is. But when asked the direct question of whether health care is a right or a privilege, his answer was, "It's no doubt it's not a right." And I think that's an actionable basis or starting point for your views on health care and who should be entitled to access. The first significant overhaul of Medicare and Medicaid occurred with the Affordable Care Act, or Obamacare. And it's been called the first Civil Rights Act of this century because its purpose, its goal, was to move toward universal care. And its premise was that health care is a right, not a privilege, for the fortunate few. When I retired after 40 years as a legal aid attorney in 2013, I became an ACA health insurance navigator, helping people to enroll in the Virginia Exchange. And the reason I did that was because in my 40 years working with low-income people, many of them, the majority of them, did not have access to health insurance. And I saw how many went into bankruptcy if they could afford a bankruptcy attorney. Nationally, I knew that 60% of all bankruptcies in this country are health-related. That's 600,000 a year out of the million bankruptcies that are filed each year. But many of my clients never went into bankruptcy, and they not only lost their health, they lost, all their finances, their families broke up, and they suffered early deaths. The very first people I represented in my legal aid career were in Florida. They were farm workers. Their average life expectancy was 56. So I had up close and personal, some just, over the years, very dramatic experiences, haunting experiences with my clients who were uninsured. Many of you may have heard of a Harvard Medical School study in 2009 that found that about 45,000 Americans died annually due to lack of health insurance. To me, that's not an academic conclusion. It was a confirmation of what I've seen over the years. I can remember clients who jumped off area bridges. I can remember clients who shot themselves. I can remember clients who took drug overdoses. And it was because they had untreated medical and usually mental health conditions. And they just could not take it any longer. And they saw no way out. So these are reasons why I became a navigator. And over the last 4 years, I've enrolled over 1,000 Virginians in the Affordable Care Act. The first year was probably the most satisfying of my life, even comparing it to 40 years as a legal aid attorney. It was just unimaginable. It was like a new frontier had opened up. We started with appointments, and there was such a demand that we went to being open 7 days a week, 12 hours a day. People lined up. People would come to their appointments an hour early. The rate for people actually showing up was 98%. 98%. That shows you how personal and how important health is. Health comes first. And when we enroll people, they would break down and cry. We had tissues on each navigator's desk. We had large boxes of tissues because people would invariably get emotional. And they were told, well, now you have your insurance. And of course, we would tell them how to utilize it. And then they would hug us and hug us again before they left. And this went across the board. We enrolled Republicans, Democrats, liberals, conservatives, Tea Party types, Trump supporters. I enrolled 3 Trump supporters the day after the election. And I won't try to explain why that is. Other than that, they were all united by a common desire to be healthy and to lead healthy lives. And it was life and death in many cases. If they didn't get the insurance, they weren't going to live. So now we found ourselves in 2017. We have 410,000 people enrolled in the Affordable Care Act in Virginia. There could be another 400,000 with Medicaid expansion. And I echo the obvious that we should expand Virginia Medicaid in Virginia. As to the Affordable Care Act versus the American Health Care Act, I would say there's certainly problems seeing this from the inside as a navigator with the Affordable Care Act. Some of the problems, though, have been caused by sabotage. Funding, the risk corridors funding in particular, in December 2014, created an underfunded mechanism, created more instability in the marketplace. Administratively, beginning next month, there will be more sabotage because they're shortening the enrollment period to 45 days from 90 days. They're going to make it much more difficult to enroll outside of open enrollment. There are about a dozen different measures that will harm the Affordable Care Act. My personal feeling is that it should be repaired, not repealed and replaced, and that the American Health Care Act is an abomination. If you want to describe it in one sentence, it's simply a tax transfer disguised as a reform of the healthcare system in this country. You've got, under the most recent CBO scoring, $664 billion, this came out yesterday, in tax cuts, which come from, quote, the savings in cutting healthcare funding in this country. And that will go to higher income families and to corporations, both inside and outside the healthcare arena. We all called, I think, to, as members of democracy, to move forward, to move for change, and to remember the words of Dr. King. And I'll leave it at that.
To create a dialogue, and I had hoped that some of these questions could be collapsed into just a few. They're all over the map. So I'm going to start by allowing Dr. Hazel to create that dialogue with our panel.
Okay, well, thank you. Great discussion, and if you came to hear about the healthcare system as is, I think you got a good piece of it tonight. It is complicated. And there is not an easy answer that I can see. I can tell you, starting with Bill, I think healthcare is an essential. The point we always have to balance is who's responsible and how do individuals act responsibly in that, particularly when we're running up the costs that we have run off. Is that liability? Is it fee for service? Is it all of these things that are important? Steve did hit on the most important reform in healthcare that no one talks about, and that's the Medicaid Payment Reform Act that was passed. The Medicare Payment Reform Act. Medicare, just to be sure, there are probably a few of you on Medicare here, is not means tested, independent of wealth and assets. You're 65 and older, for the most part you're eligible. It is a federal program. Medicaid is a state-federal partnership where the state in Virginia is roughly 50-50 is our base match rate. So the state has the option of buying into Medicaid or not on behalf of the people who are less well off. And that's really the divide. So there are two very different systems. It's really unusual when you think about our federal system in that we have a Medicare program that has been running along that's largely fee-for-service, and I think a lot of the roots of the payment problems that we've had in healthcare over the years have come from Medicare policy, paying for documentation, not for results, things like that. We have guaranteed through EMTALA, this is where Chad would say we have something from dating back to the 1980s called EMTALA. Does everybody know what EMTALA is? Yeah. Emergency Medical Treatment and Active Labor Act. It says that when you're sick enough, you can show up at the emergency room and Dr. Royston will come in and help the hospital and we will take care of you. Is that the way we want? And there was no funding for that. And that bill, if I'm not mistaken, was signed by the great socialist Ronald Reagan. So to think about an unfunded mandate on the system, we are required to take care of people when they are very sick. Your breast cancer can already have gone to the point where you've got a metastatic fracture in your femur. We'll come take care of you, but we won't get the mammogram that might have prevented that. So we made the choice in the 1980s that we're going to provide services. We just haven't figured out how to do it yet. So I would say that's an issue. To Sally's comments about mental health, I think in Virginia that is the issue right now. Mental health drives physical health costs in enormous ways. I learned as an orthopedic surgeon, you can't treat depression and anxiety with a knife. But people do things that drive them to hurt themselves because of mental illness. And you have to have that, and we are woefully behind in our workforce in that. We're working to expand that. Our training and our clinical placement for our social workers does not lead to a good career. There's a lot of opportunity for secondary trauma and burnout, and we are going to have to address that as we go through. We are working very, very closely to align what we're doing in Medicaid with what we're doing in behavioral health. And the big difference is the behavioral health system in Virginia, the public one, takes care of the most severely mentally ill who can't pay. Medicaid has some insurance and is insurance-based, and we are working to align those two. We're encouraging medical homes and mental health medical homes. We're working to try to help with the medication. The GAP program that she mentioned was not an accident. It was took a lot of careful thinking went into that. And I want to say one thing about addiction, and then I'm going to tie it to mental health. When people are addicted, who here knows somebody who's addicted? Most all of us do. If you don't, you just don't know. That would be my guess. There are only 3 things that can happen to people who are addicted. They die. We see that, or they try to die and we resuscitate them, and they try again and we resuscitate them until they come into treatment. They die. They live with the damage. Crime. The leading cause of family disruption is addiction, foster care, adoption, those issues, domestic violence, neonatal abstinence, infectious diseases. All of these things are related to addiction. So you can live with the harm or you die, or you get into recovery. But for people to sustain recovery, it requires an ability for us to take them back in and say, yes, you can have a job. And you can have a place to live and you can eat, because if you can't support yourself, you can't support your family, and you relapse. And guess what? The same thing applies for mental illness, just that this mental illness has been going on for so long, we haven't addressed it. And so we are working a lot on those areas. And to Steve's comment, cost still is an underwriting factor. We are putting our nation at a competitive disadvantage through this, but there was a group of retired generals and admirals that I remember running into several years ago that has said, you know, what percent of kids age 18 are not physically fit to go into the military? It's an enormous number, 60, 70% cannot pass the physicals going in. Now we do a lot on SOLs in schools, but we do not do much about the body that supports the brain and gives you the ability to work in life. So these are all places to work, but I just wanted to respond to some of those comments. And Linda has the other point that I was trying to make. It ain't free.
Who pays, Dr. Hazel?
Huh?
Who pays?
Who pays? Who pays? Yeah, thank you. Thank you, because when she can't take care of them in an outpatient clinic, she sends them to Chad. Who pays? We all do, and we're doing it in a foolish way, so we need to get the coverage in, and we need to make it better simultaneously. So I apologize, but they got me wound up. Questions?
There's some commonality in the questions. Sally, you gave us a number of things that are going right. So one of the questions relates to, is there a foundation on which we can build? Are there things that we are doing so well that there are opportunities to build on them to resolve some of the fundamental problems? Coming from that is it possible to tinker with the system that we have to make a fundamental change? And then building on that is it beyond the pall to deal with the cost issues that caused Anthem to lose $100 million and to withdraw from the market? Is it possible to resolve these by tinkering with the current system, or do we have to do something very fundamental, such as a single payer system? So those are the way I've tried to collapse many of these questions. I want to give it a try.
I think the answer is yes and yes. Yes to the good things. And I've always personally seen the Affordable Care Act as just a mark along the road to ultimately having universal access. That could be single payer. But just addressing the here and now with the Affordable Care Act, there's some good things about the Affordable Care Act that go to personal responsibility. And as navigators, we hit that hard. It wasn't just enrolling insurance. It was using it wisely, shopping for the doctor, and so forth, using the right medications, but living a healthy lifestyle, dealt with diet. There is a penalty in Obamacare for being a smoker, and goes up to 30% higher for the premium. So I saw a lot of people stop smoking, and that's a positive. Having to pay a penalty, again, personal responsibility, because we're all in this together. I think those are positives. But there's so much chaos right now, I think it leads to an opening, at least a discussion of single payer, because there's a lot of discussion about health insurance, insurers, and we in this country pay $500 billion a year, $500 billion a year for health insurance. And if you had a single payer system, think what could be done with that $500 billion.
And I'm sure Chad might be able to talk to this too. If you talk to physicians and hospitals and other clinicians, nurse practitioners, there is, I think, a growing tipping point. I think most physicians and most hospitals realize that the old fee-for-service system is going away. I'm sure they say the gravy train is ending, and that they are increasingly adopting a population health approach where they are focusing more on wellness and well-being and the engagement of the individual in health, and not just treating diseases, but trying to prevent and keep people healthy. We have accountable care organizations. Secretary Hazel talked about medical homes. Those are all basically arrangements where providers work as a team, no longer in silos, so that they know the complete picture of what's going on with their patients, and they also are in touch with them to make sure that they're staying healthy too, and they're not just seeing them when they're sick or they need care. So I think we're going to see, I don't think that can be stopped, particularly as we talked about because of the other legislation that as far as Medicare move in that direction at a pretty fast clip. So I think that that is very hopeful for all of us who want better health and more affordable health care.
Say something really quick in response to that question. We know the answers. We have the answers. There's a great book written by a gentleman who's an attorney at Georgetown Law, I believe it is. His name is Peter Edelman. He happens to be married to Marion Wright Edelman from the Children's Defense Fund. And since the 60s, he's been working on this issue. In his book, and I believe the book is titled Too Rich, Too Poor, he clearly says, we know what the answers are to ending poverty. We just have to be bold enough to demand that our policymakers make the right decisions. So as voters, we have to elect those people who are going to be bold. I believe Dr. Hazel alluded to this. We have some really, to use a different term, messed up policies But we have the answers, and we have the resources. We have brilliant people who can do this. We just really have to get out of our own way and make the right decisions for our entire community.
I just wanted to take a shot at this one too. It certainly is appealing to me at this point in my life and career, seeing what I've seen with Medicaid, to say, why do we have a Medicare program and a Medicaid program that have different sets of rules? And in fact, as a state, when we're trying to innovate on these dual eligible projects, the Medicare people, who always seem to know better, even though it is a smaller program and the states are not partners, they will come in and they will say, but you have to do this, this, and this, because that's the rules, and they've been fee-for-service forever. They are going to have to converge towards Medicaid, and I do think that at some point you're going to say, why are we running two bureaucracies in two different federal programs, and that will begin to align things more and will free up funds. I'm always, though, a little cautioned by the example of VA right now. This is an entirely federal-run integrated system, and in case you haven't heard, there's some pockets of not-so-excellent stuff there that are happening. So that in and of itself is not an answer. You know, we always look at where we said we want three different options, because one will go away and we still want people to have a choice. And how we get from where we are to there, I think, is difficult. But there are some common themes, and one is to begin to get the care more integrated. I was in Cuba, believe it or not, a year and a half ago, and visited some of their medical facilities, and as poor as Cuba is, they turn out a lot of doctors. I think they have about 50,000 doctors working around the world now, and their claim to fame, so to speak, is that they send a team into everybody's home twice a year. They understand what you are dealing with at home and try to intervene there before the things that cause you to have problems take effect. Now, can I say that it works and that I wasn't exposed to propaganda? No. But I do think there is something there that we need. Read Mountains Beyond Mountains by Paul Farmer about his work in Haiti, and you might begin to see some alternative ways of looking at how we address things and reduce costs. So there are some really good things going on. I think we're doing some great work being done by Ben Miller out in Colorado around behavioral health in terms of integrating. How do we make the medical system more aware and responsive of the emotional component of healthcare? It can be done, but it's going to take a little time.
We have another theme of unintended consequences. There are certain policies and resources on the table, such as the Obamacare. And the question is, how has this affected various activities, such as employers and others, in an adverse way? And then, on the other side of the coin is, what reforms, what changes would remove those unintended consequences that have?
And some of the consequences, again, a business owner as well as an employer, is that there's a huge call shift. And I think when they talk about the call shifting has gone from, we've seen it used to be bad debt or uncompensated care, charity care, has now moved to more out-of-pocket expenses that people are not able to pay, with $4,000, $5,000, $6,000, in some cases $10,000 deductibles, is that people are not able to pay. And so what we're seeing at the hospital is a growing higher acuity, and so people aren't accessing care earlier in the system. And so the Affordable Care Act was meant to have preventive medicine, to access mammography, to access primary care. If people can't afford even a $60 copay to go to the primary care physician, so we're seeing overutilization of the ED. And so some statistics is that it was meant to drive down ED visits, but if you look at the country as a whole, 12% increase in emergency room visits. And so people are not accessing the primary care offices. They're waiting till they get extremely ill and come to the hospital. And so a lot of our reimbursement is based off of DRG, so complexity of the patients, is that we've seen it has grown a third of a percentage point up, and that means, and that's pretty significant, is that patients are staying longer in our ICU, so it's more costly. And so that's one aspect of it. The other one that I'll say too, I mean, as we look at as a business owner, is that not only do us as an employer, we see double-digit increases every year in our premiums. And someone said that the losses were actually on the exchange products, because those have been shifted to the other commercial payers who aren't on the exchange. Because if you saw the news, Anthem actually made record profits in the first quarter. And so they're doing extremely well by shifting the cost to all of us here in the room.
Did we mention who pays?
So somebody's paying for it. And being having lived in other states, Texas had a high-risk fund to begin with, and so it was extremely costly to be able to do that. And that's basically what the exchange programs have really become, is those who didn't want to pay for health care, haven't paid for health care. You talked about the different aspects too, about the penalties related to smoking and smoking cessation. The penalties they're really pretty low. And so most people are willing to go ahead and pay that on their taxes and not take insurance, because it is more costly to them. So those are some of the impacts that we've seen at the hospital level. And also decreasing reimbursement is that we used to see double-digit increases from the managed care companies. We're lucky to get 1%. I know that some of the programs in the state of Maryland, we were talking to some of the physicians, are actually getting 74% of Medicare. And so you actually lose money on every single patient that you take care of. And Medicaid is usually 5 to 10 cents on the dollar that we get reimbursed, and so the reimbursement is extremely low. And so it's really forced us to be able to focus more on the expense side versus the growth opportunities, because growth outside of the ED has really started to stagnate and not seeing that significant growth that we've seen in the past.
Dr. Hazel, correct me if I'm wrong, but one of the positive unintended consequences is a growth in Medicare enrollment. As a result of the Affordable Care Act, we have more people enrolled in Medicaid now in Virginia than we did previously. I would say that's a positive.
I'm going to respond because you mentioned employers. I would broaden it though, because I think for the last couple of decades, everybody in the room has been paying for the rise in healthcare costs in a way that probably most of us don't even realize, in terms of foregone raises, because our wages have been stagnating, and largely the cost of labor has gone up, and an increasing portion of that is to pay for healthcare and health coverage. So we all as employees have been sacrificing those raises and turning that over to pay for our health coverage and health care. And so to the extent that we still have healthcare costs that rise faster than inflation, faster than the overall growth in the economy, we're still doing that. And so that's one of the reasons why employers, as purchasers of healthcare, want to see better value for the dollars that we're paying for healthcare, so that we as employers can hire more people, and also the people that we employ, we can have more of the money that we pay them in compensation go to their salaries and their wages, rather than turning that over to pay for healthcare. And so that's kind of a hidden thing, how we're all paying for healthcare, and we have been for the last couple of decades.
Another thing employers did is limited people under 30 hours of work when they did before. That was unintended because of the piecemeal way it was done. Just add on the employer side.
Yeah, and it's primarily for smaller.
Including government, we did it too.
It's primarily for smaller employers too, because they're kind of on the front lines trying to, make payroll and pay for their businesses, and so to the extent that they pay more for health care, that means that it's got to come from somewhere, and so they reduce hours or they hire fewer people. So that's correct.
I haven't heard the phrase income inequality mentioned tonight, but I think that's another elephant or another huge factor lurking in the background. Just a couple of examples. The minimum wage in Virginia is $7.25 an hour. If it was raised to $10, not only would social program costs go down, but a lot of people who are in the Medicaid gap would be eligible for very affordable insurance under the ACA. You don't see this discussed much in the press, but there's a real income stratification when it comes to the Affordable Care Act in terms of the subsidies. One of the things that would be eliminated by the American Health Care Act are the cost share reductions. Those are reductions in out-of-pockets, deductibles, copay, co-insurance. If you have income between 100 and 150% of poverty, and you choose a silver plan, which ordinarily covers 70% of your health care costs, you get 94% coverage because your out-of-pockets are almost nothing. If you're between 150 and 200%, it's 87% instead of 70. If you're between 200 and 250% of poverty, it's 83. It's 73 instead of 70. But above 250, you get no cost of reductions, and above 400%, you get no premium subsidies. In my experience, the two consumer groups most dissatisfied with the Affordable Care Act, and I'm talking about individuals as opposed to businesses, are the people in states that don't have Medicaid expansion, like Virginia, and people who are either above 250% of poverty or above 400% of poverty. And those above 400% of poverty are struggling with costs, but they get nothing. And so this is a stratification as to income that's not being addressed, but it's there.
Now, I would just add, I think that the marketplace building was done too quickly and was probably, in retrospect, in my opinion, unnecessary as part of the ACA. I think one of the good decisions we made was not to create our own. The job security, the people who tried to do that in the time allotted was not good. So I think that was a problem. I personally think that at the end of the day, we as individuals are responsible to a large extent for what we do with our own health and health care, and that the insurance should follow us, much like our savings accounts do and so forth. It still boggles my mind why business wants to hold on to that. But they do get a tax deduction that you do not get if you're unemployed and going to get it. And that was never really equalized in this thing in any meaningful way. So there's an equity on that part as well. But I think that there are smarter ways to do the insurance. If your insurer was going to have you until you're 70 and didn't hand you off to Medicaid when you're 65, they might actually care about your health.
It's at 9 o'clock, and I'm getting the hook, as is the entire panel. There were so many great questions here that we're not getting to. Lyme disease, the assisted outpatient treatment, that Virginia is one of 4 states that do not have that. Behavioral issues in terms of how to get people to look after themselves in terms of preventive behaviors. Just so many questions that we're not getting to. Perhaps the panelists can field a question or two in the lobby. But the hook is complete.
Please give us a round of applause.
The motto of the Virginia Interfaith Center is learn, pray, and act. We've certainly learned a lot today. I think we have a lot more to learn, so I encourage us to go home, to read current events, to connect with those links on the websites and find out more, and then to pray and reflect on what we want as a nation for ourselves, and then I beg you to act. We need to contact the legislators, tell them what we feel, but tell them we also expect them to solve this problem. I think too many of us walk away from it and said, But we need to say to them, we want answers, we want it figured out. So I would ask you to do that. And finally, on your packet, if you tear off the back sheet, it would take you about 60 seconds with your dog pencil. If you would just give us some quick feedback, we give these forms about once or twice a year, that would be great. You can leave them in the back. As you go out, if you haven't signed up to get emails from the chapter, please do so. And thank you so much for coming out and be safe this weekend. Take care. God bless.